So what are the basics of PBC? So let's start with the name, primary biliary cholangitis. This is the new name that was designated to PBC a few years ago when it was previously known as primary biliary cirrhosis, which was a bit of a misnomer since most patients with PBC don't actually have cirrhosis, which in medical terms means an end stage of liver scarring or liver disease. And so that's what led to this move to change the name to primary biliary cholangitis. This does lead to a little bit of confusion with another disease of the bile duct called primary sclerosing cholangitis, or PSC. And so it's important to recognize that these two entities are often confused by physicians who are not familiar with these diseases, both of which are relatively rare, both of which affect the bile ducts. This conference, of course, is for patients with primary biliary cholangitis, or PBC, but it's likely that at some point during your treatment, a physician will get confused and think you have primary sclerosing cholangitis, or PSC. There are actually three primary autoimmune liver diseases, two of which are PBC and PSC. The other is autoimmune hepatitis, or AIH. These are distinct diseases of the liver, although they share the common autoimmune basis of their disease. That means that the body's immune system is attacking a part of the body which it thinks is a foreign invader, but in fact it's just itself. The differences between these three diseases is that PBC targets the small bile ducts, while PSC targets the larger bile ducts, and autoimmune hepatitis targets the main liver cells, or hepatocytes, similar to a viral hepatitis. There are distinct differences between PBC and PSC which are important to recognize and which you can educate your physicians about if they don't already know. First, as you all know, PBC is distinctly female predominant. That is, for every 10 patients with PBC, 9 will be women. On the other hand, PSC tends to affect men more frequently than women, about 3 to 2. The diseases that are associated with PBC and PSC are also quite different. Most patients with PSC will have some form of inflammatory bowel disease, whereas this is relatively infrequent in patients with PBC. The diagnosis is much different. In PBC, of course, we make the diagnosis in most cases by the presence of the anti-mitochondrial antibody, or AMA, whereas in PSC, the diagnosis is made on something called the cholangiogram, which is essentially a picture of the bile ducts and shows these specific stricturing of the large bile ducts here. If we do liver biopsies, there are also differences between these two diseases. The classic lesion of PBC shown here with lots of inflammatory cells, these very small dark dots here around a bile duct here in the middle. This is in contrast to PSC, where the bile ducts are surrounded by a thick fibrous band of tissue, and these are quite different on liver biopsy. So these two diseases are very distinct, although sometimes physicians can get confused, and in occasional cases, making the distinction between these two diseases can be difficult. Now, once we have the diagnosis of PBC, then we need to go on to treatment. Making the diagnosis of PBC is relatively straightforward in most cases. The diagnosis is made when two of the three main criteria are present. The first criteria is that the alkaline phosphatase is elevated. We usually say 1.5 times the upper limit of normal, or ULN, for at least 6 months or 24 weeks. So someone should have a persistently elevated alkaline phosphatase to start with. We usually want to make sure that there's not another reason for this. There are more common reasons for having an elevated alkaline phosphatase. This just represents injury to the bile ducts. And so a gallbladder stone, a stricture, other causes can be present. And so we usually exclude other diseases with an ultrasound. Once we've done that, then we want to test for anti-mitochondrial antibodies and anti-nuclear antibodies. And if the anti-mitochondrial antibody is present at any level, then we can be pretty sure that we have a diagnosis of PBC. That is, we have 2 of the 3 criteria already present. And this is true in about 80 to 90% of the cases. Now, in those people that don't have an anti-mitochondrial antibody, another option rather than going to a liver biopsy is to test for PBC-specific anti-nuclear antibodies. And so if there is an ANA present, then that person's blood can be sent off for those specific anti-nuclear antibodies called GP210 and SP100. They're only performed at certain specialty labs, so sometimes it can be difficult for doctors to find where to get them tested, but this may prevent the need for a liver biopsy, which is the 3rd criteria required to make a diagnosis of PBC. And so for patients that have persistently elevated alkaline phosphatase but don't have a serum anti-mitochondrial antibody or PBC-specific ANA, a liver biopsy is needed to show the distinctive histologic or biopsy features that we see in PBC to officially make the diagnosis. Now, it's important to recognize that routine liver biopsy is no longer required to make the diagnosis of PBC, and rarely do we get it, only in those cases where we're unclear of the diagnosis because of the absence of the AMA. Now, there are a few variants to PBC that are important to recognize. There is, of course, those patients that don't have AMA, the so-called AMA negative PBC. Now, about half of them will have an ANA, and so we can make that diagnosis in that group of patients based on that. Patients with AMA negative PBC are essentially have a similar presentation and course of their disease compared to patients with AMA. There's also a syndrome known as overlap syndrome with autoimmune hepatitis, and in my experience this is overdiagnosed. This area is somewhat controversial, but the most widely accepted criteria are that you should have an ALT more than 5 times the upper limit of normal, so that means 100 to 150 at least. There should be an elevated immunoglobulin G or IgG, or an anti-smooth muscle antibody. These are all features of autoimmune hepatitis. And then importantly is what is found on biopsy. Are there findings that are more consistent with autoimmune hepatitis than simple PBC? And so this is relatively stringent criteria. It's not uncommon to have a mildly elevated ALT or to have some biopsy features that show mild hepatitis in regular PBC. And so if these features are found, it should not automatically make a diagnosis of overlap syndrome with autoimmune hepatitis. And this is important because it can affect the treatment if we make this diagnosis. There's also a very rare form of PBC called the ductopenic variant. These are individuals that have rapid loss of their bile ducts. There's severe itching, very high cholesterols, and while they may not have cirrhosis at the time of diagnosis, they usually progress very rapidly. Fortunately, this is very rare and affects probably only 1 or 2% of all PBC patients. The progression of PBC in terms of its liver disease is relatively slow. Generally takes several decades to progress from the initial development of PBC and the elevation of the alkaline phosphatase all the way through damaging of the bile ducts to what we call ductopenia, which is a lack of bile ducts, the development of cirrhosis with what we call portal hypertension and its complications, and eventually needing liver transplantation. Along the way, of course, there are also other quality of life issues and symptoms that need to be addressed, most importantly fatigue and pruritus. Now let me just illustrate the variability of PBC with 2 actual cases of patients that I've followed for a number of years. The first case is a woman who presented at 55 years and had had an elevated serum cholesterol for some time, and it didn't change with dietary changes. So her doctor wanted to treat her with the statin medication, and she had her liver test checked. At that time, she was found to have an elevated alkaline phosphatase of approximately 350. Her ALT was also mildly elevated at 60, but her bilirubin was normal. She had an abdominal ultrasound that was unremarkable and was found to have an antimitochondrial antibody. And so she was appropriately diagnosed with PBC because she had two of those three findings, that is the elevated alkaline phosphatase and an antimitochondrial antibody, and she was started on URSO at 15 milligrams per kilogram per day. And she had what we would call a complete biochemical response to URSO, or UDCA. Her alkaline phosphatase went from 350 all the way down to lower than 100 within the first 3 months of treatment, and has remained that way for many, many years, now out probably about 10 years that I've been following her. In contrast, a woman that presented somewhat younger at 41 years of age came in complaining of itching or pruritus, joint aches, and abdominal pain, and her alkaline phosphatase was 670, and her ALT was also slightly elevated at 77, and her bilirubin, while normal, was slightly above what we would normally expect in a young woman at 1.2. Her abdominal ultrasound also was unremarkable, and she had a positive antimitochondrial antibody and was started on URSO as well. However, in contrast, she had what we would call an incomplete response to URSO. Her alkaline phosphatase dropped down to just below 200, but then increased again and sporadically was elevated throughout the course of her disease. Importantly, later on in her course, her bilirubin, which had always fluctuated between the upper limits of normal to above normal, began to rapidly increase after about 10 years of disease, at which time she underwent liver transplantation. And so it's quite clear that there are two groups of patients, those that respond completely to URSO and those that don't. If we look at this graph, this illustrates the important difference between these two groups of patients. The purple bar represents patients with PBC who have a normal response to URSO, I should say a complete response to URSO. And they have a very high likelihood of surviving without a liver transplant for many, many years. In fact, if you compare this solid purple line to this dotted purple line, you'll see there's no difference between these two lines. And this dotted purple line represents people of the same age without PBC. And so PBC patients that have a complete biochemical response with URSO have a normal transplant-free survival, or a normal probability of living as a similar group of patients their age. In contrast, PBC patients that don't have a complete biochemical response have a much greater risk of either dying or requiring a liver transplantation over a course of 5 to 15 years. So it's very important to recognize this group of patients to look for additional therapies. These patients tend to be younger women, men, and possibly those of Hispanic ethnicity. We've gotten a little better at identifying these individuals, understanding that it's not simply a group that either responds or doesn't respond, but more importantly, in a sort of continuous increase in risk as these liver biochemistries worsen. So, for example, if our alkaline phosphatase starts rising above the upper limit of normal, the risk continues to go up the higher the alkaline phosphatase level. Similarly, the bilirubin level, even slightly below the upper limit of normal, increases our risk of liver transplantation and continues to increase the higher it goes. So these are the two main liver tests that we want to be looking at when we're determining whether someone's having a biochemical response to URSO or not. Now, a very sophisticated way of predicting or estimating the transplant-free survival of a patient is with the GLOBE score. And this is available online to patients as well as physicians. And what we do is we enter various parameters, including age, bilirubin level, alkaline phosphatase, albumin, and platelets, along with the normal levels from our laboratory tests. And it calculates a score and what the threshold is in terms of whether transplant-free survival is reduced when compared to an age and sex-matched population. For example, in this patient who was started on urso at 53 years of age and had a normal bilirubin but an elevated alkaline phosphatase, we see that there is a reduction in their chances of living without a liver transplant compared to the normal population. And if we look at those rates or those odds of surviving, you see they're not too different at 3 years, a little bit lower at 5 years, but they really start to drop off at 10 to 15 years. And this is very easily identified by the red here highlighted on the threshold score, as well as in these probabilities. Now, another patient that was started on treatment at 63 years of age and their alkaline phosphatase was down to 143, we see is in green, indicating that there's no difference between their chances of survival compared to a similar population. And so this is a nice tool to use to determine if you might consider additional therapies beyond urso. Now, there are other means of trying to identify your stage of liver fibrosis, and that includes FibroScan and another test called an MR elastography. This is some work we've been doing at UC Davis to try to see if these two tests are equivalent in terms of estimating liver fibrosis. And in fact, we find they're fairly equal in terms of determining patients that have advanced fibrosis or mild or no fibrosis. And so this is another tool that might be used in trying to determine whether you need additional therapies beyond urso without having a liver biopsy. That is, to have a FibroScan or other form of measurements of your liver fibrosis. Of course, fatigue is also important in PBC. This is just a study comparing both PBC and PSC, and showing that, of course, there's fatigue in both of these diseases beyond that of individuals that don't have either of these diseases. And importantly, while we don't understand completely the basis of fatigue in PBC, there's a lot of work going on that indicates that there's something centrally different going on in the brain activity of patients with PBC. And so when you ask, is it just in my head? Well, yes, it is just in your head, but it is a part of the disease and not simply a psychological fatigue that you're feeling. In addition, there is variability in terms of the fatigue that people feel with PBC. And similarly, when patients are compared with and without fatigue, there are clear differences in brain activity between these two groups, even among those patients that have PBC. So we're getting a better understanding of fatigue within PBC, but we currently do not have adequate therapy for this symptom. Now, the therapies we do have for PBC are essentially geared towards reducing the progression of the liver disease, and unfortunately not so much for the symptoms. Currently, we have 2 FDA-approved therapies, urso or ursodiol. This has been shown to decrease liver transplantation, delay the progression of liver fibrosis, and the development of portal hypertension. More recently, what I'll talk about a little bit in a few slides, is about obeticholic acid. This decreases the alkaline phosphatase levels in patients with an inadequate response to urso who are intolerant to urso. This would be predicted to improve clinical outcomes, but we're still waiting for that proof. And unfortunately, obeticholic acid has a high rate of itching and a mild change in cholesterol, which may be problematic. Other medications have been studied and some are available but not approved for use. This includes fibrates such as fenofibrate, and we'll go over some of that data. Also, some data recently published with budesonide I'll also be discussing. So the main targets that have been effective in PBC have been directed at bile acids. Even though PBC is an autoimmune disease, and we would think that targeting the immune system would be the most effective means of treating it, so far this has not been the case. And what these drugs do are either alter the makeup of the bile acids or reduce their production. So bile acids are compounds that are made by the liver and that help us digest our foods. They then are absorbed in the intestine and recirculate back to the liver. And what we're doing with urso and obeticholic acid is altering these pathways. So urso essentially dilutes out some of the more toxic bile acids to prevent their damaging effects to the bile ducts in the liver that can accumulate with the damage that's being done. Obeticholic acid, on the other hand, actually reduces the amount of bile acids being produced in the liver, as well as the uptake of bile acids into the liver. Other drugs are targeting other areas in these pathways, including the reabsorption of bile acids from the intestine, as well as targeting some of these circulating molecules, or almost hormone-like molecules, that go back to the liver and shut down bile acid synthesis. So this is a new area of research where we understand better how bile acids are regulated, and we can step in and modulate this to reduce the injury from bile acids that are occurring in PBC. This is the result from the main study of obeticholic acid, or Ocaliva. It was called the POISE study, and the study involved 3 different groups of patients. Some patients were given 10 milligrams a day of obeticholic acid. Some patients were started at 5 milligrams and then after 6 months increased to 10 milligrams if they didn't have an adequate response. And then a group of patients received placebo. And a response was defined by patients that had an alkaline phosphatase under 1.67 times the upper limit of normal, which is about 200, and had a greater than 15% reduction in their alkaline phosphatase, and had a normal bilirubin. And as we can see here, almost half of the patients, whether they got 10 milligrams a day or started on 5 and increased to 10 milligrams, had a response, whereas only 10% of the patients with placebo had a response. Now, unfortunately, many patients had itching or pruritus. Patients on placebo, of course, had pruritus, but more patients with the treatment had pruritus, and the severity was greater. In terms of needing to discontinue the medication because of pruritus, 10% of patients on the higher dose had to stop because of pruritus, whereas only 1% stopped on the lower dose of obeticholic acid, and none stopped on the placebo. And so this has led to the recommendation that patients start at 5 milligrams and then increase the dose as tolerated and as needed to normalize their liver tests. So we know that obeticholic acid improves liver tests, but is there evidence that it does more than that? And while there are ongoing studies to look to see if it improves clinical outcomes, we just recently reported some results on liver biopsies done in a small set of patients that were in the original POISE study. So patients that were enrolled in the POISE study could have a baseline biopsy before starting treatment and then 3 years after being on obeticholic acid. Unfortunately, only 13 patients had paired biopsy, that is, a biopsy done before treatment and after 3 years of therapy with obeticholic acid. What we did find, however, is that most patients either had improvement in their fibrosis score in their liver biopsy, that is, they went from higher of fibrosis or even cirrhosis down to lower stages of fibrosis, or many of them stayed the same. Only 2 of the 13 patients showed any worsening of their fibrosis between baseline and 3 years on therapy. So this data supports the idea that improvements in biochemistry will lead to improvements in fibrosis and hopefully improvements in actual clinical outcomes. There's been some concern about obeticholic acid that led to a post-marketing letter from the FDA. This was mainly concerning incorrect dosing in patients that have severe or advanced liver disease. If somebody has cirrhosis that is complicated by ascites or other problems related to severe cirrhosis, the recommendations have been to give obeticholic acid at 5 milligrams once weekly, but unfortunately this was not being observed by some physicians and is being prescribed daily. And so there were some deaths associated with this, though it's unclear if this was due to just natural progression of the disease or related to obeticholic acid. Regardless, the use of obeticholic acid in patients with advanced cirrhosis should be considered very carefully. Other medications for PBC that are not approved by the FDA but may be available to your physicians are fibrates, including bezafibrate, available in Europe and Japan, and in the US, fenofibrate. Most of the studies with these medications have been relatively small case series. There is a recent report of bezafibrate in a French study in a randomized controlled trial similar to the POISE study for obeticholic acid. In this study, patients either received bezafibrate or placebo for 2 years, and they were defined a complete response as normalization of their alkaline phosphatase, ALT and AST, bilirubin, PT, and albumin. Very high standard for a response. And they found that 30% of the patients on the bezafibrate had that response, whereas only 1% in the placebo achieved that. In terms of alkaline phosphatase normalization, 2/3 of the patients on bezafibrate completely normalized their alkaline phosphatase, whereas only 1% of those on the placebo group. There were some problems with bezafibrate in that 3 patients had significant increases in their ALT and AST, more than 5 times the upper limit of normal. This has been described before and is one cautionary note about using these medications, and it does need to be monitored. There are also elevations in an enzyme called CPK, which needs to be monitored and may lead to discontinuation. And these drugs are known to lead to increases in serum creatinine, a measure of kidney function, but the significance of this is not clear. At the recent European liver meetings, there was a report from Dr. Hirschfield and his group on the use of budesonide in patients with PBC with an incomplete response to urso. In this study, patients had to have a liver biopsy showing inflammatory activity in the liver, because budesonide is a corticosteroid similar to prednisone that is thought to work through reduction of the inflammation in the liver. Patients were treated for 3 years with urso plus the budesonide, and they had a liver biopsy before and at the end of therapy. And while there was a trend towards some improvement in liver histology or liver biopsy scores after treatment with budesonide compared to placebo, these weren't statistically significantly different. Now, surprisingly, the alkaline phosphatase did drop significantly between baseline and 3 years in the budesonide group, whereas it did not change significantly in the placebo group. This was somewhat unexpected. However, there's some caution with budesonide in that, like prednisone, it can lead to loss of bone density and that is exactly what was seen in this study with budesonide and PBC over 3 years. And so for chronic use in a group of patients who are already at risk of having osteoporosis and osteopenia, budesonide has to be considered with extreme caution in terms of its use. There are currently several ongoing clinical studies that suggest that we may have new therapies on the horizon, and I just want to review a few of those before finishing up. This is just a brief outline of all the drugs that are currently in trial or recently completed. There are several drugs that are very similar to obeticholic acid, such as the Gilead and Novartis products. There is an injectable medication called NGM282, which has also just completed a phase 2 study. And the one that's probably furthest along, seladelpar, is similar to the fibrates and is going on to phase 3 studies in the near future. Other drugs that primarily are targeting the itching of PBC are in trial. This one from GlaxoSmithKline is currently enrolling and hoping to treat the itch of PBC. And then there are the immune-based therapies. I mentioned the budesonide, which had positive results, but is not likely to be helpful for PBC, and then negative results with other immunomodulatory therapies. These are the results of the seladelpar study, just showing 2 different studies. First at higher doses, where there was about a 50-point drop in alkaline phosphatase, and this was seen with lower doses as well. So it appears that the current doses will be 5 to 10 milligrams, and we'll see where that goes in the next 3 to 5 years. So what do you need to do when you've been diagnosed with PBC? Well, first, be sure you get properly diagnosed. Do you have PBC? We talked about the 3 criteria required, and in most cases the diagnosis is correct, but if you're AMA negative, other diagnoses should be considered as well. Do you have overlap with autoimmune hepatitis? This is a very uncommon condition, so if you are diagnosed with it, be sure that you do have it, because if your doctor wants to put you on steroids or other immunosuppressants, be sure you need them. Get properly treated. That, of course, means actively managing your symptoms. And start treatment with urso at the appropriate dose of 15 milligrams per kilogram per day. This can involve a little bit of math to figure that out. I've got a table here that sort of breaks it down to the doses you should be on. It's important that you are on adequate doses of urso before you know whether you're having an adequate response or not. Once you've been on urso for 6 months to a year, you should determine whether you've had a complete response or not. A complete response would be if your alkaline phosphatase is less than about 200 and your total bilirubin is less than 1. Those are general guidelines, but if you achieve those 2 things, it's likely you're going to do just fine. If you haven't achieved those 2 endpoints, or you can't tolerate urso, then you should consider other therapies. Obeticholic acid is one treatment to consider, particularly if you have little to no itch and don't have advanced disease. Another alternative, though off-label use, would be fenofibrate. This might be better for you if you have moderate to severe itch and you're not interested in clinical trials. And the final option is to consider clinical trials if you have moderate to severe itch, there are insurance issues where you can't afford or get your medication, or if you're interested in helping others, which is really the primary motivator for people to participate in clinical trials. Thank you for your time, and again, I'm sorry I couldn't be there in person. I hope you all have a wonderful time at the conference and come away renewed with lots of new information. I'm sure others will cover many of the aspects of PBC that I did not cover. Take care and all the best.